Good afternoon, everybody, and welcome to this webinar on the role of diagnostics. Thank you for joining us. We're delighted today to be joined by two of our panelists. The first is Dr. Vicki Chalker, the Head of Respiratory and Vaccine and Preventable Bacteria Reference Unit, National Infection Service, Public Health England, and Liz Cross, Advanced Nurse Practitioner at Attenborough Surgery. Today's webinar is going to look at the importance of diagnostics in addressing antimicrobial resistance. We're going to be looking at the business case for diagnostics, the role of diagnostics, current testing speeds, costs and barriers for health professionals to look at utilising diagnostics on the way through and their role in the AMR challenges. We will be having availability for questions at the end to both panellists, and we've already got some sent in questions from a number of registered attendees. We'll also have an icon which is to wave a hand, which you can click on to actually put forward a question. We will try and save questions for the end of both presentations. However, do have any questions pre-prepared you would like to put forward and enjoy both presentations. So without any further ado, I'd like to welcome Dr. Vicki Chalker, who will start with our first presentation. Vicki, over to you.
Oh, hello everybody, thank you very much for inviting me to talk today. So I was asked to talk to you about care pathways around diagnostics and how they're implemented. Oh, and for those of you who want to know what I look like, that's my picture. So first of all, I'll start with a disclaimer. So I work for PHE and also NHS England, but all views expressed in this presentation are mine and mine alone, and not the opinion of either organisation, and I'm not going to endorse in this presentation individual products or methodologies, but in the course of the presentation I might mention some that are available or show images of some. So what are we worried about really? Well, there's rising antimicrobial resistance in a number of different bacterial species, and we're really worried about an inability to treat patients. I'm sure you're all aware of the antimicrobial resistance activities, and also the fact that the WHO has issued a list of priority bacteria with resistance, which are responsible for the highest mortality rates. And you can see this on the slide now, and it has a range of different pathogens, from sexually transmitted pathogens like gonorrhea to respiratory pathogens like Pseudomonas and also E. coli. So what is the role of diagnostics in antimicrobial resistance? Well, obviously it can help us by avoiding unnecessary treatment, optimise patient treatment and use, so switch patients to a treatment that's going to be appropriate and going to work for the infection they have. It can help in identifying high-risk patients for particular infections or treatment failure, and improve drug stewardship and development. And also has an importance, diagnostics are critical for screening and also surveillance of infectious diseases nationally. The independent review of antimicrobial resistance by Lord Jim O'Neill stated that diagnostics are critical for the appropriate use of antimicrobials, and they required or requested that a step change is needed in the way technology is incorporated into the decision-making process. At the moment, a lot of antibiotics are prescribed empirically. Currently, many decisions are based on empirical diagnosis, and the rapid point-of-care diagnostics can also enable a precise and timely diagnosis. And they wanted to implement diagnostics, or the recommended implementation of diagnostics to help decision support, to drive changes in prescribing and also response to prescribing for accurate prescribing. So which markers and things can we test and measure for? So there are different classes of diagnostics, of which I'm sure you're all aware. In relation to antimicrobial resistance, though, there are four sort of key areas. So are you looking for the bacteria or a virus? And can your diagnostic distinguish between the two? Can it tell you the type of bacteria or infection you're looking at? Can it determine the resistance? So which antibiotics will not work in the patient? And the holy grail, susceptibility, can it tell you which antibiotics would work against that particular infection? I can sense the impatience, so let's get on to the care pathways. So the power of diagnostics in antimicrobial resistance have many different arms. But today I'm going to focus on those that are transforming existing pathways and approaches to support new models of care, so integrating diagnostics into models of care. So I've recently been undertaking some work with NHS England mapping diagnostic care pathways, trying to get stakeholder feedback as to the utility of the care pathways on the ground and evaluate ultimately where in the care pathway that diagnostics would have the greatest effect on patients and NHS benefit. Look at evaluating diagnostic gaps so we can look at ultimately commissioning the research which will develop diagnostics which we require and we currently don't have under development, and work with a wide range of partners from NICE to the direct evidence cooperatives, BIVDA and industry, academia, and also patients, because obviously they're crucial. So the number of pathways we've been looking at are respiratory tract infections, sexually transmitted infections, urinary tract infections, and also sepsis. So on the screen now, it's probably very difficult for you to see, but this is the sepsis pathway mapped from the top left, if I use my mouse to show you here, from the patient's home, through pharmacy and outreach or high street settings, through GPs, ambulance, to A&E, and to ward and intensive care unit treatment of patients. And as you can see, the diagnostic step is highlighted in yellow here. And so it's very far down the pathway from the patient's starting point, which is up here. So the sepsis care pathway includes many different diagnostics, and diagnostics are complex. So the first thing is, which diagnostics should we be focusing on? Obviously there are patient evaluation systems we can use and clinical systems such as safety netting and news scores, which can give you a diagnostic-free indication of patient status. There are also physiological measures such as temperature, heart rate, blood pressure, which many can be taken in the location of the patient's home or a primary care setting. If you look at sort of biomarkers of infection, there are multiple biomarkers of infection used specifically sepsis, and there are many different diagnostics available for these different categories. And it's not really until you get to the specimens that you then get diagnostics which are specific towards the isolation or detection of bacterial species and also the sensitivity of those bacterial species to antibiotics. But there are also other diagnostics involved in the care of patients, such as imaging tests and also the surveillance and reference testings that are used. And an important aspect is the following an acute episode, the aftercare diagnostics which are required for patient care. So it's a huge undertaking to look at diagnostics all the way across the care pathway. The key messages I think we've found so far are that currently diagnostics occur very late in the pathway, and this is in fact too late for some patients. Sometimes we're aware of microbiology results becoming available after patients have unfortunately passed away, including sensitivity information. The information about infection resistance, as I've just said, can occur considerably later. There are rapid point-of-care testing now, rapid blood analytics, and rapid multiplexing tests, all of which may have huge benefit in this area and may complement the Think Sepsis campaign. If we look now at the urinary tract infection care pathway, this is just as complex, I would say, as the sepsis care pathway. And you can see that if I point with my mouse again, the culture and sensitivities here occurs very late in the care pathway once again. The diagnostics are sort of in three different categories: biomarkers of infection, detection of the microbe and infection sensitivity profiling, and imaging. And there are known diagnostic gaps which we've identified. Again, the diagnostics are used late in the care pathway, and the majority, and patients are often on prolonged prescription, such as patients in care homes with catheters. And there is a link of urinary tract infection, obviously, to the requirement for good catheter care and hydration. However, rapid point-of-care testing at sites may be beneficial for patients and reduce hospitalisation ultimately. However, there is a difficulty in diagnostics for urinary tract infection which is the determining of the infection level as opposed to the background level of infection for asymptomatic patients. If we look at respiratory tract infections and sexually transmitted infections, so there are many point-of-care testing devices which are now available, such as those for HIV, and in fact the national guidelines from 2008 stated that point-of-care testing was recommended in several different contexts. There is now internet-based home testing available for Group B Streptococcus and also HIV, and I'm not sure of how many patients are actually using the GBS online testing at the moment. There's increasing availability in different settings for point-of-care testing for Streptococcus Group A in pharmacies and other places, and also influenza A and B and RSV point-of-care testing. I'm aware of A&E departments using RSV point-of-care testing, for example, on children. There's also availability of multiplex testing for many different pathogens in one time. So instead of doing an individual test for one species, we can now do more than 15 in one go, for example. And there are also multiplex tests which can also determine not only the pathogen identification, but also simultaneously detect resistance, such as that for Mycoplasma genitalium, which cannot be isolated on a plate, so it has to be detected using molecular methods. So the care pathways for RTIs and STIs are a work in progress. So if anybody's listening with expertise or is interested at all in being involved or helping give stakeholder feedback and input into this, please drop me a line. So I hope from what I've said already that you can see that the diagnostics is really key, dependent on the setting, and the demand is altering for tests to be more flexible in the provision of the location, interpretation and treatment of patients. Patients are increasingly wanting to have an evidence-based answer closer to home. But obviously the different settings are internet-based, patient home testing, residential care-based, pharmacy-based, GP and walk-in centres, ambulatory care, A&E and also hospital-based. And different methodologies will have improved benefits or not, depending on the setting and the care pathway. For example, the use of lactate in point-of-care testing in ambulance triage or point-of-care testing in a care home. So what do we need to do to help with implementation? Well, I think really demonstrating value and patient safety is key. So we have to look at the economic impact of diagnostics across the care pathway, and we're actually looking at this now to see if we can determine at which points in the care pathway, if we implemented specific diagnostic category of tests, how many bed days would that save, and also if we can link specific infection categories to prescriptions of antibiotics, we can also look at the number of prescriptions given per infection to see if we can see improvements. There are quality aspects to consider of any test used for infectious disease diagnostics, and critically there is also the data capture issue. So the increasing use of point-of-care testing may lead to a reduced capture of the surveillance data, which is currently based on laboratory-based data. There are also issues for policymakers and the evidence required to recommend adoption nationally. And I think a key issue is the simplification of the diagnostic commissioning process. At the moment, diagnostic commissioning is undertaken with sporadic systems, if you like, across the country, and there is no the diagnostics are often within other commissioning systems as opposed to readily identifiable themselves. So there are several different diagnostic classes. I've mentioned a few already. So you can have point-of-care testing, point-of-care tests now which take minutes for infectious diseases, such as Group A strep testing. You can also have online testing where the patient will get a result themselves 24 hours later. Multiplex genetic testing for bacteria and/or resistance that I've mentioned. We can get results using that in a few hours. There are rapid identification systems which we can use for bacterial colonies using mouldy and chromogenic media, and also biomarkers of infection. So there's been a huge revolution, I suppose, in the detection of biomarkers of infection, whereas now there are tests for lactate which can give you a result in 13 seconds on less than 1 microliter of whole blood, and other tests that can give you complete blood counts on less than 0.18 ml in less than 4 minutes or 4 minutes. Another key area of development which is very exciting in relation to antimicrobial resistance is the robotics and automation for minimum inhibitory concentration determination, which tells you if the bacteria are resistant or not, and that's reducing time considerably. These tests are also very cost efficient if you're multiplexing. For example, the multiplex, so the cost, if you like, of doing all the individual tests of the pathogens shown on the left is just approximately £1,500 for a neonate. Oops, sorry about that. And the cost to do a single multiplex for this would be approximately £50. So there's a huge cost saving and time saving. If I show you the power of multiplexing, this is a specific neonatal case of a baby with worsening respiratory distress and was deteriorating very rapidly. Using a multiplex kit, we were within 2 hours of receipt of the sample able to inform the clinicians that the baby had detectable adenovirus, staphylococcal infection, and methicillin resistance. So in the future, what's going to be there then? Well, genomics are obviously key. Point of care testing genomics are under development and are showing increasing promise. Metagenomics, where we sequence everything in the sample and simultaneously can detect mixed infections, antimicrobial resistance genes, and also discriminatory infection, such as transmission chain data on the bacterial species in the sample at the same time, are under development. There is also the human pathogen genomic aspect. Why do some patients get a sore throat and others go on to get sepsis? And is there a genetic link there for infectious disease that we're currently not looking at in detail? Another aspect is the personalised medicine and drug utility. So in some patients, the use of antibiotics may have a greater effect than in others, and understanding the basis of that. So what are the key requirements of diagnostics and antimicrobial resistance? Well, my concept is cost, speed, sensitivity and specificity are key. Obviously the quality and evidence of the test itself. And good data is essential for surveillance and also decision making. So the UK AMR diagnostic strategy is basically to ensure that the right test is available at the right place at the right time through self-care and monitoring all the way to public health and surveillance. So implementation is what we need. The Lord Jim O'Neill said he calls on all governments to ensure that by 2020 all antibiotic prescriptions will need to be informed by a rapid diagnostic test wherever one exists. And Dr. Margaret Chan, Director General of the World Health Organization, has said having a rapid, low cost and readily available diagnostics is an essential part of the solution to this urgent problem. And the final quote by me right now is that it shouldn't take 15 years to put this in place, as it does currently for implementing some things into the system. It should not require more than 40 trials before adoption. So I think nationally we are not very good at joining up the trials that we undertake when we validate the use of diagnostics, and we're not very good at sharing best practice, and I think it's key that we do this if we want to really revolutionise diagnostics for microbiology. Thank you very much for listening, and I'll move on to the next speaker.
Thanks very much, Vicki. Thank you for that. That was a great presentation, and especially like the minions picture on one of your last slides. I will move on now to our second speaker. We've had quite a few questions coming in as well during the course of this, which I've got ready for our end of both speakers. So the next speaker will be Liz Cross, who's Advanced Nurse Practitioner at Attenborough Surgery. Liz recently picked up the National Antibiotic Guardian Award for Diagnostics, and she'll be talking a little bit more about her work and role of diagnostics work with Attenborough Surgery. Thank you very much. Over to you, Liz.
Good afternoon, everyone. Yeah, my name's Liz Cross. I'm a nurse practitioner in a GP practice in Hertfordshire. Minor illness clinics are my bread and butter, and I've been fortunate enough that I've been using CRP point of care testing within my clinics for coming up to 2 years, and I absolutely love it. So what I wanted to give you today is more of a sense of the work I've been doing, but also that sort of what it feels like on the shop floor. So as a clinician, sat in a clinic on my own, one-on-one with a patient, how does it feel to have the opportunity to use diagnostics within your clinic, and what does that do to your consultation? So every winter, about half my patients will come in with a respiratory tract infection, chesty cough, fevers, coughing up green stuff, and we know that most of their symptoms will get better by themselves. We know that we're overprescribing. We're trying to do our best to make sure that we prescribe only when needed, but it's hard. And you know, I found going through multiple winters that, you know, you get exhausted, the work is quite repetitive, it's frustrating. So really I got involved with the CRP testing, basically because it was born of frustration. You know, how many times can you listen to someone's chest and do everything you possibly can, but they still want antibiotics, and if you don't give it to them, you know, do they then go doctor shopping? You know, I wanted to improve the minor illness service that we were providing within Attenborough surgery. So that's why I started looking at CRP testing. So, you know, like every other GP practice, we have these posters everywhere. We've been using self-care prescription pads, we've got stuff flashing up on monitors, but still I felt that it wasn't enough. We needed something else. And, you know, imagine yourself now, you sat in your GP practice. So a classic patient that would come into me would, you know, someone would storm into the room just going, every single winter I get a sore throat, it goes to my chest, and only a course of antibiotics will clear it up. Bang, they sit down. And that's their opening gambit. Now you've got 10 minutes to turn this patient around. You know, they might need antibiotics, but for most of my patients walking in, you know, they're probably going to be okay without it. But how do you convince them without really aggravating them? How do you challenge their strongly held health beliefs that antibiotics are the answer? Okay, so most of our antibiotics are prescribed in primary care. Over half of them are for respiratory tract infections, and chances are if a patient asks for antibiotics, chances are they're going to get it. So CRP point of care CRP is a non-specific inflammatory marker. It will typically go up in over 100 if it's a serious bacterial chest infection, and it will raise up a little bit if it's viral or self-limiting. Now traditionally this is done as a blood test, and it goes to the labs, you get it back in a couple of days. Well, now there's technology out there that I can get these results back in 2 to 4 minutes. And the analyzer is about the size of a toaster, so it can sit in a GP practice. And I found it brilliant when I've not been sure whether to prescribe or not, or if the patient's particularly worried, or if they're asking for antibiotics, and there's good evidence to support its use. So what I did a couple of winters ago was I looked at using CRP point of care testing just within my clinics. Okay, and I just wanted to see, would it work or not? And obviously, being a nurse and risk averse, I followed everybody up after 28 days to see what happened to them. So I set up just a little study. It was over a 3-month period, so my peak winter months, November to January. I looked at my 18 to 65-year-old age group who came in with a lower respiratory tract infection, really following the NICE guidelines. They had symptoms for less than 3 weeks. They had one systemic, one focal symptom, but I excluded anyone who's pregnant, immunocompromised, terminally ill. They had acute pneumonia needing admission. You know, really looking at patients that, you know, may have an artificially suppressed or elevated CRP and exclude them. So really I'm cherry picking out those otherwise healthy people. And then I compared those patients with patients in the corresponding 3 months in the previous winter, because I've got that data within general practice. So up on screen now you've got the NICE guidelines. So if it's bond or viral, it doesn't even come down this algorithm. But if you're not quite sure, if you think the patient needs some extra convincing, then you can do the CRP test. So if the CRP test is less than 20, you don't need to be giving antibiotics, and you can offer them the, all the self-help leaflets, treating your infection, all the work that's come out of PHE and the target toolkit. If the result's between 20 and 100, you could think about a delayed prescription. And if it's over 100, it's more likely that it's a serious bacterial infection, then a course of antibiotics would be appropriate. So what I found was that it really changed my consultation. So in the previous winter, I would say, you'd take their history, you'd examine them, and then you go, look, this all looks very viral. I don't think you need a course of antibiotics, but the language you're using, there is that element of doubt in there. Whereas now when I've got a CRP test, I've got an objective measure. I can say, look, I know you feel awful. I know you've got these symptoms, but you're young, you're fit, you're healthy. This is good, this is good. Your CRP, we've done the finger prick test, your CRP is 10, say. There is less chance that this is a serious bacterial infection. You're going to feel awful for maybe a week or so, and then you can really talk to them about what antibiotics can and can't do. You can talk to them without offending. It takes the what does it do? It really takes the pressure off that consultation. Okay, it really meets their concerns and challenges their expectations. So the next slide shows me we've got, the vast majority of our patients have a CRP of less than 20. And these proportions, this 70, 25, 5, seems to be replicated over a number of pilots as well. So most patients fall into that category where they don't need antibiotics. You've got a 25% where you've got that middle ground where you could give them a delayed prescription, but use your clinical judgment. This is just a guide. And then you've got 5% where it's more likely they have a serious bacterial infection. A course of antibiotics will be appropriate. Okay. So this slide here is comparing one winter on another. So on the bottom here, you've got the winter where I was using my CRP testing, and on the top here is the winter where it was just standard care. And what you can see here is that I was prescribing at 31% without the testing, and then with the testing it came down to 8. But what the really interesting thing was with this project is when I followed everybody up after 28 days, the unscheduled reattendance had halved, which that was a surprise for me, and that formed the basis of the next winter. So if you get the diagnosis wrong at the beginning, you're less likely to prescribe antibiotics. You can safety net appropriately, and the patients don't come back. I've got to say that also nobody went to A&E in this study either. So it just shows that it's really important to get the correct diagnosis at the first presentation so that you don't then go on and you don't see them again. There's no unscheduled reattendance, because what you find is if a patient comes back, they're more likely to get antibiotics at that second appointment, more likely to get a chest need bloods or a chest x-ray, and they're more likely to get a broader spectrum antibiotics on subsequent appointments. Okay. All right, and then this slide shows me that I significantly reduced my antibiotic prescribing, but also I'd halved my unscheduled reattendance. Okay, and that goes through. So what I found with that piece of work was, you know, I already use point-of-care testing within my clinics. In fact, it didn't increase my workload at all. I could do the testing within the envelope of my clinic. Patients really enjoyed it. You know, you get that sort of diagnostic pleasure. You know, you know that you're giving the right treatment at the right time, and you can more accurately decide when a patient does and doesn't need antibiotics, and you can, you know, because it takes all of that anxiety out of the clinic, you can then, you know, take a step back, talk to the patients about how long you expect them to feel unwell and what they can do to make themselves feel better. So off the back of that work, I then won a seed fund which enabled me to expand the project out to 8 surgeries. So that's what we've been doing at the moment. Unfortunately, I don't have any full results to share with you at the moment. They're still being worked on. So unfortunately, I can't give you a cost analysis at the moment, but I can give you an overview. So I took this out to 8 GP practices, all in the same locality. They were all about 10,000 patient list size, and they were all high to medium prescribers according to their STARPU data. So I had 5 sites that were using CRP testing. I had 3 sites that were just using standard care, and again I tested over a 3-month period, so I could compare them concurrently. Again, what I was doing was looking to see if I was able to reduce the antibiotic prescribing, and again I followed everyone up after 28 days just to see what happened to them. Okay, so as a measure of the appetite for testing within general practice, just as an aside, I put the advert out to our CCG saying, look, I've got funding for some testing kits. I'd like to come into your surgery, help you set up some point-of-care testing. It's going to be in your peak winter months. I can't offer you any incentive, and I'm going to be asking you to do something else in your already maxed out clinics. I was absolutely blown away. I put the advert out on the Thursday, and by the Monday I had 8 practices signed up. So as a gauge of how much GPs want to be doing this on top of an already slammed clinic, I thought that was a good indicator. So obviously I expanded it out to 5 surgeries, and there were things that went really well. There were things to improve on. So the things that went well. So these are only provisional results, but my standard care group were prescribing at a rate of 67%, but my CRP testing group were prescribing at 13%. The unscheduled reattendance also halved from comparing the standard care with the CRP testing group. So there was a significant reduction. One of the interesting things that we'll be looking at as well is in that standard care group, there were 13 patients in that group that had more than 3 appointments with their GP. So you were prescribing at a much higher rate. Patients are more likely to come back, but you've got these patients where they're coming back again and again within 28 days with a respiratory tract infection. You know, there's people that have seen their GP 3-4 times within that time frame. They may have had 1, 2, 3 courses of antibiotics and then gone on to have a normal chest x-ray and normal bloods. You know, it just goes to show if you get the diagnosis wrong at the beginning, you could save all of that, potentially. We had in my standard care group, I had 3 presentations to A&E and none in my testing group. The presentations, and these are also out-of-hours presentations as well, 3% of the patients in my standard care group had additional appointments just to deal with the side effects of antibiotics, whereas my point of care testing group, less than 0.5%. Okay, it's absolutely amazing. I can't wait to get these results out there. But it does make some fascinatingly scary reading as well. But it just goes to show that, you know, there really is a need for better management of acute coughs in general practice. It's a huge amount of our workload. Okay, so other things that went well. It was easy to recruit GPs to do this extra work. It was brilliant to watch the nurses and the GPs working together on this project as well. So if you were implementing this, I know we've got a lot of people listening who are from CCGs. So things that worked well was when you had a GP and a nursing team that worked very well together, obviously. Another indicator that a practice was really going to fly with this testing kit was if it was obviously in a central location that was easily accessible. It did require a bit of monitoring though. So I did a site visit after a month just to check and see how people were using it, so iron out any training issues. I had one practice that wasn't using the testing kit very much at all, but when I did a site visit I realized that it was in a side room, it was kind of tucked away. So what they decided to do was they moved the testing kit into the duty doctor's room, so he'd have the computer, printer, and the testing machine there on his desk. So it was just really easy to use. Every GP practice, because they have a different skill mix, they have different facilities, you really need to be flexible and creative about how you're going to integrate point of care testing within your busy clinics. Okay, so those things went well. Areas to improve, I think if what I'd like to do for next winter is it's quite labour intensive collecting all this data. So I've requested some SNOMED codes just so that I can help extract that data a little bit easier. I think areas that I'd like to improve on is standardising the training package, and certainly feedback from my GPs was that, you know, they'd like to have a kind of a crib sheet, you know, some sort of easy reference guide as well, and that would help them use the testing a little bit more, so if they could shore it up. Okay, right. Interestingly, patients were never a barrier. They actually they loved it. You know, it's Chinese Year of the Antibiotic at the moment on the BBC. Patients know that that they shouldn't be taking more antibiotics, but actually when they feel unwell, if they've been, you know, 4 days of feeling horrendous, you know, they need that extra nudge that, you know, actually you don't need antibiotics. This is what you need to be doing. You really need to reassure them and empower them to go on to self-care. So actually patients really liked having that test. And having something that was a little bit more objective within their appointments. But some of the barriers was obviously money and costs. You know, we need to prove that, you know, this is either, you know, cost neutral or cost saving. And I really hope that, you know, if I can show that, you know, that there's a cost associated with all those unscheduled reattendances, all those extra chest x-rays, all those extra antibiotic prescriptions, that actually doing a test there and then in clinic is worth it. Obviously, you know, GPs have already got a lot on their plate, so one of the barriers is, you know, trying to work out that workflow, how a patient's going to flow through their clinics. As I said before, if you didn't have nursing support, or if there are other problems within your clinical team, then you wouldn't do as much testing. Okay, and one of the other things that I'll certainly be using when I take this out further is when you're setting up the projects in the GP practices, you can give them the fancy test, you can show them all of the data to support it, but some GPs already think, some GPs are, but some people think that they're already doing a good job anyway, and they don't need this within their appointments. So I think using a little bit of tapping into their competitive spirits of GPs and nurses, using some peer comparison data. So what I've done in my practice now is, I can work out exactly who is prescribing the most antibiotics, and then you can weight that for the number of patients they see, because every GP is on some are full-time, some are part-time, three-quarter time. So that can help sort of identify who the outliers are as well, and hopefully using that peer comparison, you can get people just to engage that little bit more, just go, oh, actually, I could improve, or so that's my hope. Okay, so at the moment, the data that I do have back shows that CRP point-of-care testing can dramatically reduce the number of antibiotics that are prescribed in these high to medium prescribers, that it is reducing those reattendance rates. And this kind of implies a level of patient satisfaction as well. You've talked to them about what antibiotics can and can't do, and you've empowered them to self-care, and they're not then really annoyed that, oh, the GPs are cutting back, they're stopping prescribing antibiotics, and they're going to start going doctor shopping. So my plans for the future, outside of world domination, I hope to expand this out within our CCG a little bit further. We're going to be using a more targeted approach. Again, we're going to go for our highest prescribers. We're going to be using more peer comparison data and doing some work with that, some more audits, and bringing that in as part of the training package when you're going in and setting up point-of-care testing. I'm also looking at some decision-making support tools that we've got, which allows me to look at a number of minor illnesses, so ear infections, throat infections, chest infections, UTIs as well, and with the peer support work, it guides you through all the nice guidelines, and then it has a facility to link that straight into the medical notes, but it also gives me a facility where I can actually do a personalized text message to the patient, just saying exactly what we went through in clinic, what we discussed, and the self-care package as well, and they get that all text through to their phone. So it's all about, educating patients for future appointments, and that's what we're hoping. Okay, so I am well and truly signed up to be an antibiotic guardian. I think point-of-care testing is absolutely essential. The patients love it, and the results are really encouraging, and I'm looking forward to sending those out as soon as I get them back from Southampton. And I guess that's over to Matthew.
Thank you very much, Liz. Thank you very much for a cracking presentation. Now we're going to move on to questions, and we've had a few come in, and we've got a few that we've sent in advance. One of them being from Nottingham University Hospital, which is combined with another question we've had today throughout the actual webinar. The question goes, the evidence of benefit is there, but with upfront investment required, how can we tackle reluctance to invest within PLC or diagnostics to save antibiotics? A similar question was asked today. Antibiotics are cheap, so who finds the testing investment for testing, should I say?
Matthew, you're cutting in and out.
Sorry there, Liz. The question is, the evidence of benefit is there, but without upfront investment, how can we tackle reluctance to invest in point of care to save antibiotics? And that's to both of you.
Well, I'm hoping when I get the results back from my 8-site study that it'll be really clear that there are some definite savings to be made. The number of chest x-rays that were required, the number of out-of-hours appointments, the number of additional GP appointments, you know, from patients just not getting better, or, you know, you safety, you give them antibiotics, you're no better in a week, come back. Guess what? You come back. You know, trying to tidy that up a little bit. So I've left all the fancy math stuff over to Southampton Uni, and they can shore that up for me. But I really hope that it'll be fairly obvious that it is worth making those upfront investments.
Vicki, have you got anything to add to that?
Yeah, I mean, I entirely agree that that's a really critical thing. If we're wanting people to do more work and we're going to move effectively systems that at the moment are commissioned and happen in laboratories and secondary care to primary care settings, that the money really has to be found to help people do that. I think I've looked at a number of CLP trials that are underway across the country. I think I've got more than 40 now listed currently happening, but I am aware that some of them, even after a 2-year trial, which was positively met by the patients and the GPs using them, that because of funding they were then ceased and they're not currently undertaking the use of, in this case, CLP. So I think certainly the commissioning of diagnostics nationally is something we need to look at, and we need to try and unpick, because at the moment there isn't a clear, this is how we commission diagnostics in relation to AMR. And maybe if we are quite creative with how we link the quality premiums and things for antimicrobial resistance, we may feed that back into diagnostics. But I agree, it's an issue that needs to be addressed.
Okay, one of the questions that came in today, we had lots of similar studies to that of Liz's, as you just touched on there, have been conducted across the country. So is it the cost thing which is the situation? One of the questions is, why do you think that the PLCT and CRP testing has not been rolled out in primary care? Is it because of the cost as the main barrier, or is there other particular issues to why it has not been rolled out as yet across the whole of primary care?
Well, I think that it's...
I get the feeling that...
Sorry, Liz, you go first.
Sorry. I think one of the concerns that often comes up is that potentially, you know, you could be doing, you could be doing a lot of tests on a lot of people. You know, we see so many people during the winter months that come in with chest infections. You know, all of a sudden it's a test that could be open to an enormous amount of people. And how do you target that? You know, that's one of the biggest problems, is that it's got such a massive application, and the cost could escalate.
Vicki?
Yeah, so I think that when we're making policy, instead of using words like could be implemented, could be used, that maybe if the evidence is there, it should be phrased as should be using diagnostics for specific infections. And so it's a clear mandate that, you know, this should be actually in use. I also think that for things like CRP implementation, as I've just said, you know, there are 40 sort of sites using it or undertaking trials at the moment, actually more than that. So I think it is actually increasing how we share the best practice and communicate. Well, I think it's really, that's what we need to do. We need to communicate this across the country to help people realise the benefits. So, other barriers to adoption are, I mean, often people's time, practically people on the ground working face to face with patients every day, might not have the time to spare to implement things within their local area, and so maybe we have to think creatively about what we do with our laboratory scientists. And I know of some areas where they have scientists actually going out and providing the point of care testing in sort of multi-clinic situations or lab in a bag. Well, I think we have to look at the workforce and what we're currently doing with it.
Okay, do you think that one of the questions we've had prior to the webinar today, do you believe that high-level guidelines are needed to motivate organisations to invest? I.e., as you said there about the wording could to should, do we need to see some overarching national policy changes that will make POC more will be more seen across the country? Do you think there's guidelines that need to be changed to support that, or is it more to do with, again, back to the cost issue?
My opinion is that yes, we do. I think we do need guidelines. We need guidelines on quality standards, on the minimum sensitivity and specificity that's acceptable for infectious disease diagnostics, and we do need. I think we do need high-level, clearly documented. This is what we expect people to be undertaking for microbial infection detection and resistance and sensitivity testing. But I think that's not the only thing. I don't think just saying sort of a high mandate, this is what you should be doing, is the answer. I think a lot of it comes down to communication and using the workforce on the ground and showing the benefits of the expertise, such as the one that Liz has been doing, to say to people that if you do this, it can reduce your prescribing, it can reduce your reattendance, and showing the evidence, but communicating the evidence and actually communicating the fact that it's not that difficult, and sharing experience. As Liz said, she provided assistance in one practice just by moving the location of the reader, and having people like Liz, I think, willing and able to share best practices is excellent.
Yeah. Liz, did you work with a local PLCT coordinator? That's a question from one of our registrants today.
No, I didn't.
Right.
I really missed a trick on that one.
Yeah. So with that in mind, actually, the PLCT coordinators, how vital are they to implementation across primary care?
I think they're essential just to make sure that we're doing all the quality checks. It's okay for me to manage a small group of sites, but if this was to be commissioned more widely, you need the support from the labs there to make sure that everybody is ensuring that their testing is up to quality standards.
Yeah. Finally, last question I want to put to both of you, starting with Vicki. What one thing would you like to see changed in relation to POCT diagnostics this year? What is the one thing you would wish on the wish list to see in order to advance the role of diagnostics? That's to Vicki first.
I'm just thinking about it. It's an interesting question. What I'd like to see is sites adopting multiple point of care testing. So for example, for respiratory tract infections, looking at RSV, influenza, group A strep, all these things where we have point of care tests which are good quality and can be used. I'd like to see people using both, actually using them for more than one infectious disease at a time. So really embracing them for the patients, I think.
Yeah, great. Liz, your wish list.
My wish list. I like to see this implemented in all our highest prescribing areas. I've done snapshot audits of high, medium, and low prescribing practices, and some of our practices are doing an absolutely fantastic job, and it probably wouldn't make any economic sense to put point of care testing in there. But I think, if if your local data shows that your out of hours or your urgent care or some of your practices are struggling to get their antibiotic prescribing down and still manage the expectations of patients, then I'd like to see point of care testing as something they can sign up for. So I'd like to see it incentivised.
Brilliant. Well, thank you to both our panellists today, Liz Cross and Vicki Chalker. With this in mind, we will be sending the slides and the recording of today's webinar out to our registered users, and we have had a couple of questions about that, so slides will be made available possibly within the next 24 to 48 hours. Further to this, we'll be also publishing and sending out our recent diagnostic survey. Further to Vicki was talking about before about the evidence-based approach and seeing the demand and the need and the current work within laboratories and at primary care level. We recently conducted a survey which we had a number of respondents to, talking about the role of diagnostics from their perception. So we'll be sending out the summary of the evidence out to everybody in the next coming week. Alongside this, for all of us, we'll be hosting the UK Diagnostic Summit on November the 8th at the Wellcome Trust in London, where we will be putting diagnostics at the point of agenda. Vicki will be joining us with a number of other senior experts and leaders to talk about the role of diagnostics, not just at AMR but wider, including diabetes, cancer, sexual health and other key areas. So this is going to be talking about diagnostics. Hopefully by November the 8th we may have further information from a policy level about the role of diagnostics, but we do hope that some of you will join us down there, which is free for health professionals to attend on November the 8th in London. Once again, I'd like to thank both our panellists today for their time, which we appreciate, and we hope you enjoyed today's webinar, and we look forward to seeing you again. Thank you very much.